Good morning, everyone, and welcome to today's webinar. Our topic is a great one today. It's understanding the 3Ds: delirium, depression, and dementia. And as always, these complimentary webinars are brought to you through a collaboration of sponsorship with O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, as well as Alzheimer's Orange County. And my name is Kim Bailey, and I'm a gerontologist here at Alzheimer's Orange County, and I will happily be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial to anyone who cares for and works with older adults. So we hope that you find today's presentation especially informative and useful. And we're lucky because today we have our own Lauren Weiss from Alzheimer's Orange County. And I'll tell you more about her in just a few minutes. But before I do that, let's go over what you need to know to get CE credit. Okay, so CE credit is available for RCFE administrators, licensed RNs and LVNs, and for LMFT, LCSW, LEP, and LPCC professionals through the CAMP and the BBS. You must be online for the full 60 minutes. You've got to have access to both audio and visual on your computer. If you want CE credit, don't share your link to join with others, okay? Don't share that link. It's unique to you. It's your unique record of attendance, and if you share it or use someone else's link, you're not going to be able to receive the CE credit. Please answer this series of poll questions immediately. This is proof of your active attendance. If you have any problems at all with the mechanism, you can simply put your response into the chat, but we do need to hear from everyone receiving CE with each of these questions. So there is a survey that you need to complete immediately as you exit the webinar. You will only receive a survey link by email if you don't complete the survey when exiting the webinar. So the email with the survey link is sent out 24 hours after the end of the webinar. And this link is, again, unique to you and your attendance. So please don't share it with others. So basics for everyone, your mic and video are disabled, but it doesn't mean you can't ask questions. We hope you'll type your questions into the chat box located in the Zoom toolbar, and I'm going to be saving those questions for our presenter once she finishes. Once she finishes the presentation, we'll do a little Q&A. Okay, so with that, let me tell you a little bit about our speaker today. So she is Lauren Weiss, our Educational Services Manager at Alzheimer's Orange County. She has 15 years of experience in dementia care with a specialized focus in educating care providers and enhancing the quality of life for individuals who are affected by dementia. Lauren holds a BA in psychology from Cal State University, Fullerton. As a certified dementia practitioner with a specialized certificate in Montessori for dementia and aging, Lauren understands the complexities of cognitive health and uses her knowledge to educate and ensure those living with those who are living with dementia will experience the highest quality of care. So with that, I'm going to go ahead and turn it over to Lauren. Thank you, Lauren, for being with us today in this capacity.
Great, thank you. It's so nice to be on this side of the screen for this presentation. As Kim mentioned, I will be talking about understanding delirium, depression, and dementia, also known as the 3Ds. And today we're going to define and differentiate delirium, depression, and dementia. We'll recognize signs and symptoms of each, understand how they can overlap and be misdiagnosed, and learn basic intervention strategies and when to seek help. Older adults, especially those with medical illnesses or cognitive challenges, are at risk for all three conditions. And these conditions can look similar, but their causes, treatments, and outcomes are very different. Misdiagnosis can delay treatment, cause emotional suffering, or even lead to a preventable decline. So let's break them down one at a time, and we're going to start with delirium. And this is a classic case study of delirium. Mrs. Anderson, an 80-year-old woman, was admitted to the hospital due to confusion and altered mental status. Her family reported that over the past 48 hours, there has been a sudden onset of disorientation, agitation, and incoherent speech, with it getting progressively worse at night. Mrs. Anderson had a history of hypertension and started a new medication over the past week, but is otherwise considered healthy. Delirium is a new or worsened confusion. And with delirium, there will be changes to a person's mental abilities, and it affects thinking, memory, awareness, and focus. And the hallmark symptom of delirium is the inability to sustain attention. And this can mean distractibility, inability to focus, drowsiness, or semi-consciousness. So some examples that you may see are falling asleep in the middle of a sentence or becoming distracted by sounds. Symptoms will appear within hours or days, and overall delirium happens when your body or brain is under too much stress. So we're going to start off right away with a poll question.
Okay, let's go ahead and see what that looks like. So the question is, the inability to sustain attention is a hallmark symptom of delirium. Is that true or false, audience? Go ahead and weigh in quickly. Once again, the inability to sustain attention is the hallmark symptom of delirium. Okay. As I mentioned before, if for any reason you have trouble inserting your answer into the poll box, you can just put it in directly into the chat box. So I think we'll just give it a few more seconds here. And let's go ahead and end the poll and release our results. And it looks like everyone did really great on this. So good job, team. And back to you, Lauren.
Okay, wonderful. Okay, the signs and symptoms of delirium, those include saying or doing things that may seem strange or uncharacteristic for them, or just don't make sense in general. They may be easily distracted and find it hard to pay attention. They don't know where they are or what time it is, or they're seeing or hearing things that don't exist or hallucinations. Rapid and unpredictable mood changes, or forgetting things that recently happened. And some other symptoms of delirium can include sleep schedule changes, so being awake at night and feeling tired during the day, delusions or believing things that are proven to be not true, confusion or difficulty processing what they see, including identifying objects, disorganized thinking, and trouble concentrating, feeling restless or having difficulty staying alert, maybe mood swings, especially agitation, anger, depression, or irritability, and trouble speaking clearly, answering questions, or understanding what others are saying. And as you can see, a lot of these symptoms of delirium are very similar to symptoms of dementia. Difficulty remembering things that recently happened, difficulty paying attention, hallucinations, and delusions. So as you can see, this is what makes it so challenging to successfully diagnose. There are three types of delirium. There is hyperactive, hypoactive, and mixed motor type, which is a combination of both. With hyperactive, it's predominantly restless and agitated. So we'll see an increase in motor activity. The person is hyper alert and easily startled. They're probably restless, or maybe are wandering. And again, those mood swings versus hypoactive delirium, which is predominantly drowsy and inactive. So we can see a decrease in activity, the speed at which they complete tasks, the speed of their speech, or even the amount of speech. They might have a reduced awareness of their surroundings. They can be listlessness or not have energy or motivation, and they can be withdrawing. So they're becoming more isolative. And so, as we see with hyperactive delirium, again, they share a lot of symptoms with dementia, while hypoactive delirium is commonly mistaken for depression. And again, a person can have a combination of both. So while they may have increased motor activity, they might become more withdrawn, or maybe they're not talking as much, but they're wandering. So we can see both. Again, delirium happens when your body or your brain are under too much stress. So example of these stresses are serious infections, being in a room without windows or sunlight, certain medications, s- medical equipment like IVs or catheters, new or sudden pain, not getting enough sleep, not moving around, trouble hearing or seeing, or a surgery or a hospital stay. And in fact, nearly 50% of patients over the age of 70 will experience episode of delirium during hospitalization. And what are the risk factors for developing delirium? Age, definitely 75 and older are at a higher risk for developing delirium. People with existing depression or dementia, and people who have broken their hip or had major surgery or functional impairment, all meaning that they're not able to move around and may be bedridden. People with previous brain disease or brain damage, sensory impairment, especially hearing or visual, and frailty. And it's important to remember delirium is temporary and reversible, but it requires immediate medical attention. So this is a handy mnemonic when trying to determine the cause of delirium. You're going to want to ask yourself, is the person in pain? Has urinary retention been excluded? Are they urinating frequently? Is there possible infection? Could the person be hyperglycemic? Are they eating enough? Do they have their dental aids, such as dentures, or perhaps they need assistance with eating that they're not receiving, so they're not able to eat enough? When was their last bowel movement? Are they drinking enough? Could there be an electrolyte imbalance? Are they dehydrated? Are they taking all of their regular medications? Or has there been an additional new medication added to their routine? And have there been any changes into the environment? Is there noise or activity that may be impacting their sleep or rest? And again, delirium is treatable and reversible, but it's important that we capture it quickly. So, what are some complications of delirium? We can experience aspiration pneumonia, bed sores, weakness, which is leading to the loss of mobility and overall the loss of independence, falls and injuries, combative behavior, malnutrition and dehydration, cognitive impairment, and dementia. But again, there are treatments for delirium, and delirium is treated by addressing the medical problem that caused it. So, for instance, if the person has high blood sugar, then they are given insulin. Or if they have an infection, they are given an antibiotic. There are no FDA approved medications for delirium, but there are some medications that may manage causes, such as benzodiazepines to help with alcohol or substance withdrawal, antibiotics for infections, and antipsychotics for severe hyperactive delirium. As a caregiver, a friend, or a loved one, it's important to remember you know the person with delirium best. And if the person is not acting like themselves, say something. And for those of you that are maybe meeting this person that's experienced delirium for the first time or on a short term basis, maybe let's say at a hospital or a skilled nursing facility, do not automatically assume that this is their baseline. Ask questions. What was the person like before they got to your establishment? Again, delirium is temporary, but symptoms can linger, especially if it's a severe case of delirium. So, if delirium is not treated quickly enough, those symptoms can linger after the delirium has been treated. There are a couple screening tools for delirium. For clinicians, the confusion assessment method, or the CAM tool, is the gold standard for screening for depression. As you can see, it measures acute changes in attention, alerted level of consciousness, and disorganized thinking. So again, this is a screening tool for professionals. For families and informal caregivers, there is the SOUR 7. And this is the only approved tool that may help families identify delirium, and it can be used to help communicate concerns to a doctor or a nurse. So, this is a tool for caregivers, family members, friends to do themselves and then take to the doctor, the nurse, whatever type of professional, and say, I'm concerned about my loved one. I think they may be experiencing delirium. And what those questions are, they look at altered level of awareness to the environment in any way different than when they are normally awake. Is there reduced attentiveness, an ability to focus on you during the interaction? Fluctuation in awareness and attentiveness, such as drifting in and out during an interaction or through the day. Disordered thinking. So the response, whether verbal or action, is unrelated to the question or the request. Disorganized behavior, purposelessness, irrational, under-responsive, or over-responsive to request. Unexplained impaired eating or drinking, unable to perform the actions to feed oneself, and unexplained difficulty with mobility or movement. So again, all of these 7 questions are for the caregiver, the family member, the loved one to ask themselves about their loved one and then take this information to a doctor. There are several ways to prevent delirium, and it's important to focus on providing person-centered care for the best outcome. You want to stimulate the mind, promote daily socializing, reading, listening to music, or conversations that help remind older adults what day, month, and year it is, and get them engaged in something that they love that will give them purpose. Having a clock and a calendar in the at-risk person's room is ideal. You want to get them moving. You want to encourage physical activity at least 3 times a day. And you want to make sure that they're sleeping well and using techniques to help promote relaxation and sufficient sleep. In seeing and hearing, you need to ensure that hearing aids and glasses are available at all times if needed. Often, families may keep hearing aids or glasses at home while a loved one is in the hospital or skilled nursing facility for fear that they will get lost. Hearing aids, as we know, are very expensive and difficult to replace. So while the intention is understandable, it's important to focus on the risk of that person not being able to hear the environment, and especially in a new environment, they're at risk for delirium. Making sure they're staying hydrated, ensuring plenty of fluids are taken throughout the day to avoid dehydration, and eating nutritious food that is available throughout the day, and promote eating with others for a social experience if possible. And again, we want to make sure that the person has their dentures if they have them, or they're getting assistance with meals if needed. Sometimes when we have someone new come to us, we may not know, do they have dentures? Do they need dentures? Do they need hearing aids? What kind of assistance were they getting at home? So it's always important to ask questions. And if you notice something's off, say something. And how do we manage delirium? Many things that can help prevent delirium can also help manage delirium. And delirium can be very scary for those that are suffering from it. So, having a family member or friend stay with them to remind them where they are, to reassure them, and help keep them calm can be very helpful. So, what should you do if your family member, your friend, the person that's receiving care, what do they develop delirium? What should you do? Place a soft light in the person's room at night. Remind them where they are, the date, the time, and the season. You want to gently assure them that they are safe and all is well. Make a list of family, close friends who are able to stay with the person around the clock. Bring familiar photos into the room and softly play music that they enjoy. And now we'll move on to depression. Mr. Martinez, a 68-year-old man, was brought to the clinic by his daughter, who expressed concerns about her father's recent changes in mood and behavior. His daughter reports that over the past few years, Mr. Martinez has become more withdrawn and spends his day in bed, shows little interest in activities he once enjoyed, and has lost weight. His daughter also reports that he has difficulty falling asleep and wakes up frequently at night. Depression is a mood disorder characterized by persistent sadness and loss of interest for at least 2 weeks. So, this person must be experiencing persistent sadness and loss of interest for at least 2 weeks. Symptoms that we may see with depression include sleeping more or less than usual, loss of interest in usual hobbies or activities, low energy levels, eating more or less than usual, difficulty concentrating, being agitated or irritable, and feeling guilty, worthless, or helpless. And along with apathy, depression is one of the most common emotional symptoms in Alzheimer's disease. So typically we think, okay, well, this person's experiencing Alzheimer's disease. Well, depression goes hand in hand, but it can be two separate things. So we'll do poll question number 2.
Yes, and it is. Another true false. To diagnose depression, sadness and loss of interest must persist for at least 2 weeks. Audience, is that true or false? Once again, to diagnose depression, sadness and loss of interest must persist for at least 2 weeks. Okay, as I mentioned before, if you're struggling at all with the poll box, you can leave your answer in the chat box. All right, we'll just give it a few more seconds, I think. Jessica, it looks like you put your hand up. If you have a question, you can put it in the chat box. Okay, let's go ahead and reveal the results. All right, everyone did a fabulous job. Way to go, team. Next, back to you, Lauren. Thank you.
Wonderful. Great. Thank you. And now, what are the causes and risk factors for depression? A cause can be illness, and several illnesses can cause depression. And those include illnesses that affect oxygen intake, such as asthma, bronchitis, and congestive heart failure, or other illnesses such as diabetes, heart disease, autoimmune diseases, and chronic pain. Some medications, such as beta blockers, steroids, and sedatives, may cause depression. Loneliness and isolation and loss of identity or purpose. And very often we see an increased risk of depression for those that recently retired because they no longer feel like they have an identity or purpose once they stop working. And risk factors include gender. Women are at a higher risk for depression than men due to a combination of biological, hormonal, and psychosocial factors. Genetics, certain personality traits such as low self esteem or being self critical, bereavement, the loss of a spouse, child, friend, or family member, financial problems, and abuse can all increase our risk for developing depression. There are several screening tools for depression. The three that I'm going to go through all look at different factors. So this in front of you is the Patient Health Questionnaire, or the PHQ-9. And this is a screening tool for depression, and it assesses the severity of depression. It can be given to anyone that is 18 or older. And one limitation of the PHQ-9, though, is that it includes some somatic symptoms such as sleep and appetite, and those may be due to aging or medical illnesses rather than depression, so it can potentially inflate scores of older adults. So some of the questions are little interest or pleasure in doing things, and the PHQ does look over the past 2 weeks. So over the past 2 weeks, has there been little interest or pleasure in doing things, feeling down, depressed, or hopeless? Trouble falling or staying asleep or sleeping too much? Poor appetite or overeating? trouble concentrating, speaking too slowly, or the opposite, or being so fidgety and restless, and thoughts that you would be better off dead or hurting yourself. And two things I'd like to point out is the being so fidgety or restless that you have been moving around a lot more or overeating, and the difficulty and doing things. So as we can see that, or I'm sorry, trouble concentrating on things, and we can see those are very similar with delirium as well. Now, the geriatric depression scale is screened specifically for depression in older adults that are 65 years and older, and it's including those with mild cognitive impairment. And this is a screening tool only, and it's not to be used for diagnosis. So if you are concerned about depression, you can do this yourself and then take it to your doctor to facilitate a conversation. These 15 questions are yes or no. Are you basically satisfied with your life? Do you feel that your life is empty? Do you often get bored? Do you often feel helpless? Do you feel full of energy? So it's looking a pretty comprehensive look. And again, it is only a screening tool. It is not a diagnostic tool. And it's specifically for those that are 65 years and older. And then there is the Life Satisfaction Index short form. This measures overall life satisfaction and well-being. It does not measure depression, but it does capture positive psychological states and quality of life, and it is useful in getting a more complete picture of emotional health. So these questions range from strongly disagree to strongly agree. And so as I grow older, things seem better than I thought they would. I am just as happy as I was when I was younger. These are the best years of my life. I feel my age, but it does not bother me. And compared to other people my age, I make a good appearance. So again, strongly disagree to strongly agree. And while this isn't looking necessarily at depression, it can let you know, are you satisfied with your life? Is there anything that you want to work on? Maybe you're unsatisfied with your life, and that puts you at risk for depression and allows you to put preventative measures in place and start working on that. So again, we have those three screening tools. The PHQ can be used to diagnose depression, and it focuses on the severity. We have the geriatric depression scale, which is again just a screening tool, and it can help facilitate a conversation with the doctor. And then the life satisfaction index form, which helps you to take a look at your life to make sure that you're living a life that you're happy with. And it gets a complete picture of emotional health. And how do you prevent depression? You want to focus on lifestyle factors, early intervention, promoting mental well-being, and avoiding triggers. And what does that all look like? With the lifestyle factors, you want to make sure you're getting regular physical activity. Exercise, even moderate activity like walking, can release endorphins that can improve mood and reduce stress. Eating a healthy diet that's full of fruits and vegetables and whole grains can positively impact your mental health. You want to get adequate sleep. Aim for 7 to 9 hours of sleep per night, as sleep deprivation can exacerbate depressive symptoms. And maintain social connections. Have strong relationships with friends and families, and that provides valuable support and it can help combat feelings of isolation. And focus on stress management. Developing healthy coping mechanisms for stress, such as mindfulness or meditation, or engaging in hobbies, can prevent stress from escalating into depression. Now, early intervention looks like recognizing symptoms. You want to be aware of the signs and the symptoms of depression, such as that persistent sadness, loss of interest, and changes in sleep and appetite. And you want to seek help early. If you notice signs of depression, seek professional help promptly to prevent the conditions from worsening. And long-term maintenance. If you have experienced depression before, consider long-term maintenance treatment to prevent relapse. And those suffering from depression, the seeking help early can be a very difficult conversation. It can, one, require you to have a difficult conversation with yourself and go to a doctor and be open and willing for change, but also with depression comes you don't want to do anything. You don't have that motivation, and it can be hard to put those steps in place to talk to the doctor. But seeking early help, reaching out to friends and family for support are very important. You want to promote mental well being, and that is engage in enjoyable activities, participate in activities that bring you joy and fulfillment. Practice self care. You want to do activities that promote relaxation and well being, such as taking a warm bath, reading a book, or spending time in nature. And seek support. Don't hesitate to reach out to friends, family, or a therapist for support and guidance. And avoid triggers. Limit alcohol and substance use. Alcohol and drugs can worsen depressive symptoms, and manage stressors. You want to identify and address potential stressors in your life, such as work related pressures or relationship issues. It's important about limit alcohol and substance use. People think, oh, I'll have a drink, I'll feel better, but it's actually doing the opposite and it can make your symptoms worse. There is treatment for depression, and that can be counseling either through a psychologist or a psychiatrist. There are support groups. It's important to focus on socialization and joining hobbies or clubs. Medication is available for depression, and most importantly, early identification and treatment. Now, on to dementia. Mrs. Thompson describes episodes where her husband gets disoriented, especially in unfamiliar environments. She notes that he has difficulty completing familiar tasks, such as managing finances or preparing meals, and additionally, she is concerned about his declining ability to recognize close family members. Dementia is a disorder of the brain that can affect learning, memory, mood, and behavior. It is a progressive decline, and onset is generally slow and develops slowly over several months and years. And the person with dementia will have difficulty with performing familiar tasks, problem solving, confusion, changes in personality or mood, and loss of initiative and poor judgment. And we'll go ahead for question number 3.
Okay, the onset of dementia is generally slow and develops over months and years. Attendees, is that true or false? Go ahead and choose your response. Again, the onset of dementia is generally slow and develops over months and years. Okay, we'll give it just another minute. And I think everybody's had a chance to weigh in, so we'll go ahead and share the results. And it looks like everyone did another fantastic job with this poll question. So good work, everyone. And back to you, Lauren.
Okay, wonderful. Now, dementia causes and prevention. So, what are the risks and causes of dementia? Age, the 65 and older. And as we get older, our risk for developing dementia gets higher. Women are at a higher risk for developing dementia, genetics, head trauma, other health conditions such as heart disease, high blood pressure, diabetes, social isolation, how we live our lifestyle, and depression. And how do we prevent dementia? Unfortunately, there is no cure. All we can do is prevent or lower our risk of developing dementia. And that looks like diet, stress reduction, and maximizing and compensating. And what is maximizing and compensating? Maximizing protective features involves actively adopting lifestyles, factors that can address health concerns to promote healthy brain and lower dementia risk. Again, the 6 pillars of brain health, managing cardiovascular health, and addressing hearing loss, as hearing loss is one of the greatest risk factors for developing dementia. And then you want to compensate for potential risk. And this aspect focuses on strategies that aim to offset or counteract the impact of factors that might increase the individual's risk for dementia. And this includes building a cognitive reserve by actively engaging in education and cognitively and socially stimulating activities, address specific health concerns, and maintain a motivational reserve. High motivation and engaging in goal-oriented activities may help develop new neural pathways and connections. These are two of the many, many, many screening tools that are out there for dementia. The Mini Mental Status Exam, or the MMSE, detects cognitive impairment and problems with thinking, communication, understanding, and memory, while the 88 dementia screening helps to discriminate between normal aging and mild dementia. So there are many screening tools. The 88 dementia is a great, is more for a care partner can do that at home, while the mini mental statics exam, the BIMS, the slums, all of those are for a clinician to provide. Now looking at the three overlapping, as we can see, all three conditions share similar symptoms and signs. And these 3Ds share many common symptoms such as apathy, which can be present in dementia, and depression, and memory loss can be present in all three. And that makes it so difficult to identify which D the person is suffering from. So clarifying the diagnosis is the first step to effective treatment, but this can be difficult due to comorbidities. So elderly patients who experience memory impairment should be screened for the depressive symptoms, since they may be suffering from depression with pseudodementia, that is cognitive impairment traditionally believed to be related to the presence of depressive disorder. So if someone's experiencing memory impairment, the best first stop is to do a depressive screening tool. But all three of these need an accurate diagnosis and effective treatment, and the only way to do that is by assessing and doing a thorough assessment for each one. Now on the screen, to make it nice and easy for you, because we went over so much information today, is all three at a glance. So just to review those one more time, we have dementia. The onset is slow and insidious. Deterioration is progressive over time, while delirium is a sudden onset and it happens over hours or days. And the duration can be hours to less than 1 month, but it can be longer. It really does depend on when treatment is done. And depression, the onset, again, recent change in mood persisting for at least 2 weeks, and it can coincide with life changes, and it can last for months or years, and again, depending on treatment. For dementia, the symptoms are progressive over a long period of time, and it is not reversible, while delirium is short and fluctuating, often worse at night and upon waking, and it's usually reversible with treatment of the underlying condition, while depression is typically worse in the morning, usually reversible with treatment. And for what are we expecting to see the symptoms? With dementia, we are seeing wandering and exit seeking, agitation and withdrawal. Hyperactive delirium, we'll see agitation, restlessness, and hallucinations. Hypoactive, we'll see sleepy or slow moving, and mixed alternating features of the above. And with depression, usually withdrawn, apathy, and it may include agitation. So again, we're seeing that all three of these share such similar features. For someone experiencing dementia, they'll generally be alert. With delirium, it's going to fluctuate. They may be very hyper vigilant. They hear a sound and they go, "What's that? What's that? What's that?" Or they can be very lethargic and non-responsive. With depression, their normal amount of alert. Same with paying attention. With dementia, it's generally normal. With delirium, there's impaired or it fluctuates, difficulty following conversation. And again, that is the key. And with delirium and depression, it may impaired, so they may not seem as if they're paying attention. With mood, with dementia, depression may be present in early dementia. And with delirium, there's going to be fluctuating emotions. So, for example, there may be anger, there may be tearful outbursts, or their fear. We're going to see those mood swings. And with depression, there'll be a depressed mood, lack of interest or pleasure in usual activities, and changes in appetite. We can see an increase or a decrease. With dementia thinking, there might be difficulty with word finding and abstraction or abstract thought. Delirium is going to be very disorganized, disoriented, and fragmented. And with depression, it's intact. Themes of helplessness and hopelessness are present, but their thinking is intact. And lastly, with perception, dementia, you'll see misconceptions usually absent. Misperceptions, I'm sorry, are usually absent, and this can be present in Lewy body dementia. Delirium is distorted. They might be seeing illusions, hallucinations, delusions, difficulty distinguishing between reality and misperceptions. And with depression, perceptions usually intact. Hallucinations and delusions are only usually in very severe cases. So again, how we perceive reality between dementia and delirium can be very similar. Someone more in the middle stages of dementia can experience hallucinations and delusions and trouble differentiating between reality and their own misperceptions of the environment. So again, it makes it that much more difficult. So overall, understanding the differences. So given the similarities, it can be very difficult to identify again which D a person is experiencing. So it's important to have knowledge of the person that's experiencing delirium. So what were they like before the onset of the symptoms? And what they are experiencing now will help figure out which D. So one must know the characteristic features of each condition and establish the baseline cognitive status and mood. And this involves attaining the patient history either from medical records and or family caregivers and conducting a depression, cognitive, and delirium screen. And when there is an overlap of symptoms, so all three for delirium, depression, and dementia, symptoms that we see in all three are present in this individual, it's recommended to treat the delirium first and then move on to the depression. And most importantly, verbalizing any concern to a healthcare professional. Just saying, is this delirium? Can be helpful as it's often overlooked. When someone goes to a hospital or a skilled nursing facility or they move into an assisted living, they're in a brand new environment with staff that does not know them. They do not know their baseline. They do not know what's normal for this person. So you as the loved one, the family member, the care partner, you have a responsibility to say, this isn't normal because they may, a doctor may see this person that's wandering or getting agitated and think, oh, that's dementia. Okay, we'll move on while you know that that wasn't your loved one 2 days ago. So it's just important to express this concern of, is this delirium? Just a very simple question and have the doctor or the nurse look into it and to help decide and do a full thorough assessment. So overall, it's important to understand the differences and similarities of the 3Ds. Delay in treatment can have serious consequences of an older person's health and well-being. We want to monitor and assess regularly as early detection is vital for all of the 3Ds. And we want to reduce risk factors and prevent where possible.
Okay, thank you so much, Lauren. That is, oh my gosh, such a valuable topic and critical information for all of us. And so we want to give all of you a chance to ask questions if you like. You can put those into the chat box now. While we're doing that, I want to remind everyone of oh, let me turn my camera on. Yeah. Hello, here I am. I just want to remind everyone of the importance of being aware of implicit biases. And another way to frame that is be aware of unconscious stereotypes while we're caring for others. And a best practice, it was actually mentioned by Lauren, and that's the person-centered approach, where we view each person that we care for as an individual with unique needs and preferences. We treat them with dignity and respect, even when they are very different from ourselves. If we always listen carefully and respectfully so that we can understand their perspectives, values, and preferences, we will build trust and provide the highest quality of care. So always a timely reminder. All right. And then also, before we do the questions, I want to just use this opportunity to once again thank our fabulous sponsors. We have, on an ongoing basis, O'Connor Mortuary, Care Choices, Hospice and Palliative Services, and Caring Companions at Home that bring us these wonderful topics and presenters. So, and speaking of topics and presenters, next month, mark your calendar for Tuesday, September 9th, and we're going to be looking at wandering in persons with dementia. And we're bringing back a very popular speaker, Erin Palposi. I don't remember what her maiden name was, but you've seen her before on these webinars in the past, and she's very popular and well liked. So that'll be really informative. And then, of course, we're doing all kinds of other education. All you have to do is go to our website at www.alzoc.org to learn more about the many classes that are actually organized and put together by our Lauren Weiss. So let's go ahead and go with the questions here. Are you ready, Lauren? Do you want to come back on camera?
I'm here. I'm ready.
Okay, good. Well, let me start with a great comment. Not a question, but a great comment. This has been so informative and educational, exactly what I needed in this phase of my loved one's journey. Thank you so much for this. So I thought I wanted to share that with you,
Thank
Lauren.
you.
Okay. One of our attendees is saying when her father, who is prone to UTIs, would go to the ER after presenting symptoms of delirium, it would be so difficult to get the providers to think that his behavior was baseline, not to think that his behavior was baseline.
Yes. I that is a very common. I've spoken to a lot of people who just think that it's the worsening symptoms of Alzheimer's or dementia, either from the medical staff or the family. But it's so important to advocate, and it's exhausting as the caregivers. You expect these people to take care of your loved one and get a little bit of break, but having to be very vocal and standing up for your loved one. This is not their normal. And please help, and escalating it if needed, calling your insurance, going to hospital administration. You can even call the Department of Health if needed, to advocate for your loved one.
Good. Yeah, she went on to add, Lauren, that, her dad's 98, so they just automatically assume it's dementia.
Right, can be very
So,
dismissive.
yeah, so we need this presentation for the
Yes.
hospital personnel, don't we?
Yes.
All right. A comment, we always need to think we're starting each person from a blank page rather than a template.
Oh, love that.
I love that. That's right. Everybody needs their own approach because they all present differently and have different needs. Um, let's see. Is there a new class for the person with dementia? Um, I'm not sure. I guess I can answer that. We do have a class for people with dementia. They're in the very earliest stages, and it's called the Memory University. And we invite the person living with early stage dementia and their primary care partner to attend together with other couples or families, and they learn about next steps and get an opportunity to bond with one another. So that's one of our lovely programs, Memory University. Um,
And then we also have just our general classes. If you're looking for just more information on what is dementia, we have Dementia 101. Kim's doing a presentation in September at Oasis on early memory loss and what that looks like. So please feel free to reach out to myself if you have questions about our upcoming classes.
Next question, is there a cure for dementia?
Unfortunately, there is not. All we can do is prevent and slow the symptoms. And that particularly looks like focusing on the 6 pillars of brain health that I spoke about: getting a good diet, exercise, sleep 7 to 9 hours, socializing, getting your brain engaged, and managing medical conditions.
Absolutely. Thank you. What if no underlying medical condition like a UTI or a respiratory infection is present, but delirium is happening? Will it eventually pass? That's a great question.
That's a great question.
Yeah.
Something has to be going on for there to be delirium. Something is stressing the body. So it may not be necessarily observant, but taking a deeper dive. Is there a change in environment? Has there been changes to their hearing? Maybe there is a misdiagnosis, a missed infection, or some other type of underlying diagnosis. But there overall should be something causing that delirium. Um, but left untreated, it will not get better. So if someone's experiencing delirium and you're not quite sure what's causing it, it won't get treated and therefore the symptoms will remain.
Thank you. Um, how long does it generally take to cure delirium?
It depends on the cause. It can be treated within hours or up to months, but again, it's really determined on what's causing it and how quickly it's identified and treated.
Thank you. Does general anesthesia cause delirium?
It can.
Okay.
I'm not going to elaborate on that one. I'm not the one,
So,
the expert of that, but yes, it can cause delirium and it
so
can.
do we, so do we want to like advise people to talk to the anesthesiologist about that
Yes,
or anything?
yes. So
Okay.
always talk, thank you, Kim.
Yeah.
Always talking to the doctor about risk factors of surgery and anesthesia. So if your loved one has dementia or is maybe at risk for delirium because they're going to have surgery to repair a broken hip or heart surgery, what does that look like? What does that recovery entail? Will they be bedridden? Will they understand, okay, you can't get out of bed, but they have dementia and there may be that miscommunication? So it's really important that before that surgery, talking to the doctor and go over the risk and the benefits because delirium can definitely be a risk of anesthesia and surgery.
Okay. Thanks. Important question. Um, would you mind going over the pinch me slide again?
Yes.
That would be great. Thank you. And Margot, I see your hand is up. If you have a question, you can just type it right into the chat box and we'd be happy to take that.
So again, this is the pinch me. We're looking at pain, infection, nutrition, constipation, hydration, medication, and environment. So taking a deep dive into all of these to see if they could be a possible cause of delirium. So again, environment, is it noisy? Perfect example is a hospital. They're not getting sleep. There's someone checking in on them frequently. That can cause delirium. Are they having a bowel movement, drinking enough, eating enough? Is there a new medication? Or maybe going from home to the hospital, a medication they routinely took at home was not being given at the hospital. That could be causing problems.
Okay, good. Thank you. Um, what types of medications, oh boy, what types of medications are best for depression?
There are several different types, and I will leave that up to specialists to determine what is best. There are, again, risk factors. So um, it's best conversation between you and a prescribing doctor or a psychiatrist to go over that because they do have different risk factors, different side effects. So what when
Right.
what's important to you, right? If you're okay with weight gain, then maybe this one's okay, but if not, then there's this one.
And I guess it depends on like if the person has dementia too.
Hmm.
Sometimes drugs don't work the same for them as they do for other people, right? So it's very
Oh, right,
individual.
right.
Um, could delirium be attributed to long-term isolation, loss of daily activities that began during COVID lockdown? So all of those negative outcomes as a result of COVID, could that have caused delirium?
It could. Isolation is a risk factor for delirium as well as not socializing. But those are also risk factors for depression and dementia as well. So if somebody started experiencing those symptoms during COVID, but they're still experiencing them now, it's important to talk to a doctor. And again, you want to do a screening tool for all three, because those are unfortunately causes that can cause depression, dementia, and delirium, isolation, and lack of socialization.
Okay, good. Um, Once a person experiences delirium, is there a higher likelihood of it reoccurring when there's a UTI or some trigger like the environment? When something triggers, is that, are they more likely to get delirium again?
Not necessarily.
Mhm.
That's a great question. Not necessarily, um, but they are at risk for developing delirium again, but not necessarily a greater risk of developing delirium. But
Yeah.
also being very aware, okay, you now know what caused it the first time and what were those symptoms that they were experiencing, and maybe being able to capture it sooner
Hmm.
rather than waiting. Because again, people, when with dementia, when someone has a UTI, which is very, very common, those it exacerbates the symptoms of dementia. So we just think, oh, okay, well, their dementia is just getting worse,
Right.
rather than
Right.
thinking it's something completely separate causing that. Okay, well, it's actually the delirium causing these symptoms. It gets remedied. So sometimes treating a UTI with someone who has dementia can take longer and is not identified right away.
That makes sense. And there was something else I was thinking. It was on the tip of my tongue. Oh well, it'll probably resurface. Um, let's see what else we have. Can, oh, I already asked that. Okay. I think that's all of them. A couple more comments I wanted to share with you. Thank you for those tips. Absolutely, we need it. Thanks, Lauren. You presented important information, and Lauren, the class was extremely informative.
Oh,
Thank you
good.
so much. Haha.
Wonderful.
Oh, I know what I was going to say. Takes a minute. Um, when we see people acting out in dementia, if there's a new behavior and it's sudden, the onset of it is sudden, we should think medical, and that's when I really, figure it might be a UTI or something like that, right? So it's just something to
Right.
kind of keep in mind. It's so hard to do these assessments of all these conditions, isn't it?
It is. And again, like that's what the whole presentation's about, right? Is
Mm-hmm.
how there's so many symptoms. But yes, that's exactly right. If we have somebody experiencing dementia and something brand new happens, even if it's in the same vein of, oh, I know my person with dementia might start experiencing hallucinations and delusions,
Mm-hmm.
still get it checked out. Still talk to the doctor. And we always want to push and advocate for our loved ones because, again, the nurses, they don't know our loved ones the way that we do. And so you go in and you say, My person with dementia is experiencing hallucinations." And they're going to be like, okay, yeah, that's what we expect to see, but
Normal.
that's normal, right? So, but saying, okay, this actually happened, right away. It was out of nowhere starting, 2 days ago, and this isn't normal for them. And I
Mhm.
want to get tested for a UTI or do labs, but really advocate for your loved one. And then
Absolutely.
I was looking at the comments too. Charles, someone asked to go over the depression causes and risk factors.
Okay.
So real quick, just the illnesses that can cause depression. Those are illnesses that affect our oxygen intake. So asthma, bronchitis, and congestive heart failure, but other illnesses can be diabetes, heart disease, autoimmune disorders, and chronic pain. So I just wanted to add that.
Great. Thank you, Lauren. Someone's asking about the PowerPoint slides. Didn't they go out automatically to everybody who registered?
They did. I did modify the slides a few after this morning. I was very busy doing that. I can resend out the slides to everybody that attended today.
Okay, that would be lovely. All right, I think we're at the end of oh, there's one more and then we are done. Is sundowning a form of delirium? Are those are
So
severe sundowning?
so that is a great question because we have wandering and restlessness is a type of hyperactive delirium. However, sundowning, as we know, is a symptom of dementia. So again, we want to look at when did it happen? And then need to do a deep dive. Okay, doing a delirium screen. So that wandering and the restlessness that we do see in sundowning and that agitation can also be seen in hyperactive delirium.
Right. Thank you so much, Lauren. That does bring us to the conclusion of our webinar, and we want to thank Lauren so much for this excellent presentation and for sharing her time and expertise with us.